A lung just collapsed, and if the trachea is shifting away from it, you have seconds, not minutes. Welcome to this rapid-fire clinical breakdown. Today we're targeting a massively tested NCLEX topic, pneumothorax. We're totally stripping away the textbook fluff here to give you the exact, high-yield tools you need to crush this exam. Listen, I really want you to internalize this life-or-death scenario right now. When you see this pop up on an exam, you aren't just answering a multiple-choice question. You're recognizing a patient who is rapidly crashing into obstructive shock. It's real-world, high-stakes stuff. All right, let's jump right into Section 1, Mechanics of a Collapse. So let's build this cascade of disaster step by step. Think of it kind of like a domino effect. Step 1, air sneaks into the pleural space, maybe through a chest wall injury or a ruptured blub. Step 2, that absolutely vital negative pressure vacuum, it's lost, and the lung just collapses like a deflating balloon, which leads to Step 3. With way less lung volume, gas exchange plummets and hypoxia sets in. But while here is where it becomes an absolute nightmare. Step 4, a tension one-way valve forms. Air is being sucked in with every single breath, but it can't escape. The pressure just keeps rising, trapping all that air. And finally, Step 5, that immense trapped pressure shoves the mediastinum toward the opposite side, literally crushing the heart and great vessels. Your venous return, it drops to 0. Moving on to Section 2, spotting the key signs. Okay, so what does this actually look like in your patient? Here's your classic presentation for a simple pneumothorax. You'll see a patient complaining of sudden, sharp pleuritic chest pain, along with dyspnea and tachypnea. But the true hallmarks, the absolute giveaways you literally must memorize, are decreased or completely absent breath sounds on the affected side. And you pair that with hyperresonance when you percuss the chest. Why? Because there's no lung tissue expanding there anymore. It's just an empty space completely full of air. Next up, Section 3, tension pneumothorax emergency. Let's compare these two side by side, because this is a huge NCLEX trap. In a simple pneumothorax, the trachea stays right in the midline, and we generally just let the lung re-expand using a chest tube. Simple enough, right? But in a tension pneumothorax, that trapped air pressure violently shoves the trachea. It is deviated away from the affected side. This is your massive, blaring red flag. If you see tracheal deviation, jugular venous distension, and hypotension, you are looking at obstructive shock. You absolutely do not wait. You release that pressure now. Which leads us directly into our ABC-ranked priority interventions. Number 1 in bold red, immediate needle decompression. You're going to use a large bore needle right in the second intercostal space, mid-clavicular line. And hear me on this. This is a clinical diagnosis. You absolutely, under no circumstances, wait for a chest x-ray. Once you relieve that trapped air and reverse the shock, number 2 is placing a definitive chest tube hooked up to water seal drainage so we can re-expand that lung. And number 3, of course, you support the patient with high Fowler's positioning and plenty of O2. All right, Section 4, priority chest tube care. Let's lay down the absolute ground rules for chest tubes. If you look at the water seal chamber and see tidaling, that gentle rise and fall with breathing, that is entirely normal. You just monitor it, no big deal. But if you see continuous bubbling in that water seal, that is a glaring red alert. It means there's an active air leak somewhere and you must immediately assess the system's connections. Finally, the golden rule: never ever clamp the tube routinely. Clamping traps air and directly causes the exact tension pneumothorax we just worked so hard to decompress. Always keep the drainage system upright and strictly below chest level. Time to lock this in. Section 5, NCLEX test yourself. Read this scenario carefully with me. A trauma client develops sudden dyspnea, absent breath sounds on the right, tracheal deviation to the left, and hypotension. The nurse recognizes A, simple pneumonia, B, tension pneumothorax requiring immediate decompression, C, pleural effusion, or D, anxiety attack. I'm going to give you 3 seconds. Drop your best guess in the comments. 3, 2, 1. Boom! If you chose B, you absolutely nailed it. Think about it. The affected side has absent breath sounds, but the trachea is shoved all the way to the left, away from the problem, alongside hypotension. That exact combo equals obstructive shock from a tension pneumothorax. It's a massive emergency that demands immediate needle decompression. Okay, let's hit question 2. A nurse notes continuous bubbling in the water-sealed chamber of a client's chest tube. This indicates A, normal functioning, B, an air leak in the system, C, the lung has fully re-expanded, or D, the tube should be clamped immediately. Lock your answer in. 3, 2, 1. And the answer is B. Remember our table from earlier? Tidaling is normal, for sure. But continuous bubbling in the water seal always signals an air leak. And we can immediately rule out D entirely. Clamping the tube routinely is a super dangerous NCLEX trap because, as we learned, it can cause a fatal tension pneumothorax. Look, we've covered a ton of ground today. But if you take away only one single powerful fact from this entire explainer, let it be this. Tension means the trachea deviates away from the affected side, and it means you decompress now. If this breakdown finally made the concepts click for you, make sure to hit subscribe. We're delivering one killer Med-Surg topic every single day until you pass the NCLEX. So, the only question left is, are you ready to spot that tracheal shift and save a life on your next exam? Keep studying hard, and I'll catch you in the next explainer.